Hello everyone, I am Leonard, and this video I will go through my idea on a clinical decision support system to help enroll patients for clinical trials related to tuberculosis meningitis, especially in developing countries where there are limited resources to manage clinical trials in terms of finances and technologies. I am going to start with some clinical backgrounds on tuberculosis meningitis or TBM. It is basically the tuberculosis infection of the central nervous system, which is a form of tuberculosis. Some studies have shown that the mortality of untreated TBMs is 100%. It is a very difficult disease to treat using common available antibacterial agents due to poor penetration of these drugs into the central nervous system where infection site is. In developing countries like Vietnam, where I originally come from, tuberculosis and TBM are still a burden to global health. Fortunately, there is a great number of clinical trials on TBM being conducted on different novel treatment regimes. These trials are mainly funded by the NGOs such as the Wellcome Trust, the Medical Research Council UK, or the WHO. As you can see on this slide, the terminology of TBM has already recorded in the SNOMED terminology database, already categorized. Up to date, a large proportion of clinical trials is still involved with paper-based data collection and management processes, including patient enrollment process. This could require great consumption of manpower and time resources. For each clinical trial, several study coordinators and nurses will be required to monitor an enrollment of patients, as well as following up with scheduled patient visits. The study doctors could be too busy to remember all the enrollment criteria or experimental treatment program before enrolling the next patient. Therefore, a clinical decision support toolkit would be helpful to increase enrollment accuracy and reduce time consumption. My proposed clinical decision support model is summarized on this slide. This is based on a clinical trial where additional novel antibiotic treatments is used on top of routine treatment for TBM. For the next slides, I will go through the input and output of this clinical decision support model. In the input section, for each patient, the study nurse will enter the following details: whether or not the patient has signed the consent form, age, diagnostic confirmation of TBM by routine diagnostic process. The study nurse will also enter the values of estimated GFR, bilirubin, ALT, cerebrospinal fluid gram stain result, pregnancy status to check if the patient is eligible to be enrolled. Next, the stratification purpose, the HIV test results, and the Glasgow Coma score grading will also be entered. For your additional information, stratification process is used to ensure equal allocation of subgroups of participants to each trial condition. Once all data have been input, the clinical decision support system will generate the following information. A separate module can be built to randomize the patient, meaning that the patient may receive active intervention treatment or relevant placebo. In this specific clinical trial, the active intervention treatment will be rifampicin and levofloxacin. The daily dosage will be automatically calculated based on the patient weight. The backbone TB oral treatment will also be generated based on hospital formulary. In this case, these are isoniazid, rifampicin, pyrazinamide, and streptomycin. Dexamethasone has been shown to increase survival rate for patients. The doses here will be generated based on patient weight, grading of TBM, and weekly dose titration. Unfortunately, the study doctor will have to refer to the national guideline to treat concomitant HIV, if there is any. In this particular model, a HIV treatment guideline can be incorporated for the clinical study staff to read. And finally, the CDSS model will generate follow-up schedule and send reminders. In this case, the follow-up visit will be scheduled weekly in the first 2 months, then monthly 3 to month 9. And the CDSS model is designed for end users such as study coordinators, study nurses, study doctors, and investigators. This clinical decision support system can be used as a standalone module or to be integrated into the existing electronic patient data report system. So far, this model doesn't support routine diagnosis and treatment for TBM and can only apply for clinical trials with novel intervention treatments. Obviously, data validation can be applied in real time to avoid mistakes and to flag up any out-of-range values. As you can see on this slide, the Glasgow Coma scale, which is a neurological scale to assess the patient conscious state, has been built readily in the open EHR database. Unfortunately, I haven't found any other archetypes related to tuberculosis meningitis on the open EHR database. There are some limitations for this particular model. This model can only support the patient enrollment and in clinical trial intervention part. The routine diagnosis and treatment of TBM need to be built in another module. Secondly, if the patient has a serious concomitant disease such as cryptococcal fungal infection, then we should seek advice from the specialty consultant. And for patients with concurrent HIV infection, a separate module has to be built to incorporate the HIV treatment regime. These are the references that I used for this presentation. Thank you for listening and please provide your feedback on PSA. Goodbye.